Welcome to the Health Babes podcast. Today we have Dr. Sam Madeira on, and he is going to talk all things testosterone with us today. We talk about the low testosterone epidemic in teenage boys and men. We talk about causes of low testosterone, causes of low sperm count, hormone replacement therapy, and a lot more. So let's get started.
Thanks so much for coming on. We're going to talk a lot about men's health today. Thanks for coming on.
Thanks for having me. Looking forward to this.
So why don't we dive in and start talking about low testosterone, the epidemic in teenage and boys and men today?
Yeah, so low testosterone, as you said, is definitely an epidemic that I think that a lot of people are not aware of, or they're not aware of how prevalent it is. And myself and my colleagues who work with a lot of guys with low testosterone are seeing that boys, teenage boys, 17 years old, young men in their 20s, early 20s with low testosterone, and even in some cases lower than men in their 70s. So it is a huge problem. It's becoming more of a problem every year. And a lot of it has to do with toxicity in the environment. Of course, lifestyle plays into that.
Yeah, for sure. So when you say, can you dive in a little bit more to like some of the underlying causes?
Yeah, so there's specific toxins in the environment that have been researched and shown to directly cause infertility in men and low testosterone. So those include things like bisphenol. So bisphenol A gets a lot of attention or airtime, I guess, in our communities. But there's also bisphenol S and F. And what happens when the chemical companies replace one chemical with another, thinking they're going to do better by all of us, is it actually gets worse. So BPF is actually worse than BPA. So if you have a plastic water bottle that you're drinking out of on a regular basis and it has BPA-free label on it, it still could have other bisphenols in it, and that can disrupt. So these chemicals are like plasticizers. They're used in plastics and things like that. If you're putting things in a plastic cup or water bottle and that's staying in your car on a hot day in the summer, or if you live in a hot climate, you're basically drinking plastic tea. Or a lot of times people are drinking out of plastic water bottles anyway, because it's kind of hard not to when you're traveling, right? So that's a huge problem. And then there's other herbicides and pesticides in the environment. So specific herbicides we know are carcinogenic, even though the chemical organizations list them as non-carcinogenic or probable carcinogens. And people probably don't want to find out that they're carcinogenic. So that's kind of my answer to that question. Well, they're probable carcinogens. Well, do you probably want to get cancer?
Good point.
So it's and I see a lot, unfortunately, in the fitness industry, because with Men's Health, a lot of guys are big on listening to their fitness coaches, and I like fitness coaches. I have friends that are fitness coaches. I've used fitness coaches. I think they're great. However, what I see with a lot of these people who are like influencers almost is they're just kind of like, it doesn't matter. You don't have to not eat organic. Just do your best getting your macronutrients in, and then take your supplements. And I think, maybe if you're helping somebody just get to a certain place, that's a good starting place. But that's if that's as far as you get, then you're really doing people a disservice and kind of sharing misinformation or not the whole story. So if someone just says, well, just take this protein powder, it doesn't matter if it's clean or not. There are certain protein powders like Vital Proteins that has a label on it now. It's sold in Costco and some other big box stores. And it says this may have contaminations in it. So, but it's not recalled. It's still on the shelf. So if you think about it in comparison, the food industry in comparison to maybe the car industry, where major car manufacturers like Toyota is a respectable car. They recalled something to do with their clutch or something like that a couple of years ago. Maybe it was 4 years ago now. But they recalled all of those cars. So even if the car didn't have a problem, they're pulled off the line or they're pulled in to their service centers and they pay for it to be fixed. But in the food industry, they just kind of say, oh, well, this could be a problem. It's up to the consumer to deal with it. I mean, if we did that with cars or airplanes, there would be mass casualties and accidents. So I think there's a long way to go here. There's a huge problem. Roundup gets a lot of airtime. I think a lot of people don't understand how bad that is for us. And it is estrogenic. Roundup is estrogenic for men and women. So it can cause breast cancer in women, potentially prostate cancer in men, lymphomas, probably leukemias in kids, and things like that. So a huge issue. So if maybe you're not concerned about your hormones, but maybe you have a family history of cancer, and men who have HIV can still get breast cancer. So I think a lot of people only think about, oh, well, in my population, like most of my male patients that I work with aren't concerned about breast cancer. But if someone's working with HIV patients or people with Lyme disease or immunocompromised in another way, they still could get breast cancer if they're eating poorly. And unfortunately, this can get expensive because if you're eating all organic and then you're taking high quality supplements to try to detoxify, because even organic foods and organic wines and organic beer still have a little bit of glyphosate exposure. And one of the biggest exposures in beer is hops. So what they do is before they harvest hops and certain grains that end up in beer, like barley and wheat, is they spray the hops in wheat and barley to dry it. So it's not even an herbicide used at that point. It's another application. So at least 2 applications before harvest. So if you're drinking as a male or female, you're drinking a lot of hops, like IPA beers, if that's your thing. I'm in Seattle right now, and even when I go to Montana for my clinic there, microbrews are really popular in a lot of these places, and other places too. And if you're drinking that IPA that you love on, Friday night or whenever after work, even if you're having one a day, that's 7 a week. Right. And you're basically drinking Roundup tea. So that's a huge problem. And I think, we can test this in people's urine. Great Plains Lab has a urine test. So you do organic acids, and then you add on a simple glyphosate test. And then there's 2,4-D, which is 2,4-D was one of the main ingredients, from my understanding, is of Agent Orange. So in Vietnam during Operation Ranch Hand, there's a whole book on this. The men in the U.S. military were spraying Agent Purple, Agent Orange, basically these different herbicides to kill the jungle so that they could better see, the people that they were fighting in this kind of guerrilla warfare. And everybody who was exposed to that pretty much got cancer, and most of them died. Like 80 to 90% of those men and women, mostly men at that point in history in the military in the US, died. And I've actually met somebody who was part of that operation, and he survived cancer. And he said everybody who was in his group in the army over there died. All of his friends are dead from cancer. So I think a lot of people just aren't aware of this history. And it's also painful to kind of assimilate or swallow these facts or these truths. So a lot of people reject it, right? So if you have, an everyday person, they're retired, they just want to get their testosterone level up. Maybe they need a testosterone prescription. And then you start going into their diet diary, and it's like, oh, you finish half a bottle of wine a night with your girlfriend or wife. Yeah. Okay, well, we need to cut that back to 2 to 4 drinks a week. And and there's resistance because that's kind of like their reward for working their butt off their whole life or their whole days. And that's how they quote unquote unwind. And, all three of us know other ways that you can unwind at the end of the day, go for a walk with your family, walk your dog, maybe exercise, sit and drink a calming herbal tea while watching the sunset. And that actually feeds your nervous system instead of completely wrecks it. So, I mean, I'm not against people having a couple drinks a week, but what I see most of the time is that people, and this is April Alcohol Awareness Month, people are drinking in excess and they aren't connecting the dots that, oh, okay, my sleep is horrible. I have anxiety, I have depression, I have low hormones, I have irritable bowel disease, I have inflammation in my gut. Oh, that's great. You're doing intermittent fasting or you're doing a 24-hour water fast once a week. But then on the weekend or Thursday through Sunday, you're completely binge drinking with your friends on the golf course or wherever and completely wrecking your gut all over again. So it's like this detox retox thing. And we're all in quote unquote the matrix. So I think what I usually share with my patients is there's no shame in my recommendations or my prescriptions of lifestyle. Probably you guys feel the same way. You both feel the same way with your clients and people you talk to. So when someone says, hey, I'm drinking 5 drinks 3 to 4 nights a week, I don't have any judgment or shame. But if they're saying, hey, I want to feel like a professional athlete when I'm in the gym and I work 50 hours a week and then I'm slamming down 15 beers a week, I'm going to say, well, most professional athletes I know, or people that are fitness trainers and are lifting, the maximum weight of their life in their 40s in the gym, don't drink at all. So how can we build some congruency here between your goals and what you're actually in your actions? And if there's resistance there, then it's kind of like, well, maybe your goals are either not really your goals or you're just not willing to do what it takes to get there. And maybe you can have 2 drinks a week and still get there. But I think that a lot of, and then there's a whole issue with alcoholism, and alcoholism is very prevalent in men and women. I would say more prevalent in men, and also kind of maybe if they're a functional alcoholic and people aren't that close to them, maybe it's not really ever called out, or it's actually celebrated. Like, hey, look at this guy. He can slam down like 12 beers every night and then he still shows up to work the next day. But his wife and his kids are the ones that are seeing and feeling the fallout from that behavior. So I think, most people who drink are not alcoholic, but there's a lot of heavy drinking that is basically culturally acceptable, and I think a lot of people,
hormones. It is.
Yeah, it's completely trashing their gut, their hormones, their gut microbiome, and Roundup's an antibiotic. It's actually the only patent on it is as an antibiotic, and it completely wrecks the gut and pulls out nutrients out of the gut and stuff like that. So, and there's a lot of other toxins that cause problems for hormones that, people who are listening, if you want to go to research sources, there's a great book called Countdown by Shayna Swan. If you're not a book reader, you can listen to Shayna Swan's interview with Joe Rogan, I think was about a year ago. And she talks about the infertility or the subfertility epidemic in men, and then even boys who have smaller testicles, smaller penises being born, who have a shorter, there's something in the research with hormones with babies that they measure the distance from the genitalia to the anus, the anogenital distance. So ADG, or AGD. So basically that is a measurement to show androgen levels. So baby girls should have a shorter distance, baby boys should have a longer distance. And what's happening is that distance, they're seeing it shorten continuously across the board with baby boys being born in the last, I believe, 10 years or so. And so that explains the riddle of why are, 20-something-year-old young men have lower testosterone than some of the male patients I've worked with who are in their 70s or 50s. And, they'll have like a 300 or a 250 or a 350 total testosterone and a very low free testosterone level. And they're, just not making enough testosterone, and they're, 22.
Wow.
And it's mind-boggling. Why are these guys not making enough testosterone? So their moms were exposed to a lot of chemicals, and then the baby in utero is exposed to a lot of chemicals. So, and intergenerational chemical exposure is also an issue. So biologically, grandma in this situation, so that the 20-something-year-old guy's grandma was exposed to all these chemicals, and then she may even been exposed to, depending on her age, DDTs, et cetera, things that aren't used anymore that actually are forever chemicals. So they stay in the environment for long periods of time, and they've been banned from the US, but they're still, their metabolites are in the environment and people are still being exposed to them. Yeah. So her ovaries, the eggs in the ovaries, are being exposed to those chemicals, and that's the young man's mom, basically. So I think we often think, oh, well, we do, I do intakes and I ask about chemical exposure and things like that, and have questionnaires, like toxin questionnaires. And someone could say, well, in my lifetime, I don't really recall being exposed, and maybe they still were and they just don't know. And that's why we do lab testing. But if you look at intergenerational exposure, then that's a major issue. And then you throw into the mix things like EMFs in everywhere now after the pandemic. A lot of people are working remotely. They're on their computers and devices almost 20 hours a day in some cases, or exposed to them 24 hours a day with EMFs, and things like mold toxicity wreck the thyroid and the gonads and mitochondria, as well as the gut and the gut-brain axis, and then make people more sensitive to EMFs. So you could have somebody who maybe works for a tech company. Now they're working remote. They were working 10-hour days. Now they're working 12 to 13-hour days because they don't have to commute. So that commute time is another 2 hours a day they can work. So they're exposed to more EMFs from their computer. And then if they're in close proximity to neighbors who have a lot of EMF output as well. So I'm just seeing a lot more people who are telling me they're sensitive to those things, and I listen to my patients. I don't say, oh, you're just making it up. I think they're actually having an issue. And some people aren't even aware of that could be an issue. So I think that's important to bring up. And we're just starting to kind of understand the science of EMFs and 5G. And some people, I think, say they understand a lot of this stuff. But I think there's a lot more to be revealed. And, the interplay with epigenetics, genetics, toxins, gut microbiome, we're also at the infancy of understanding that science. We understand a lot more than we did 12 years ago when I was in naturopathic medical school, but there's still so much more to be revealed. And even just recently, probably in the last 2 or 3 years, they started doing animal studies and showing that Roundup was for sure estrogenic. So I think a lot of people are kind of, they may have not have heard of these things because it's just the science is new and cutting edge. And there's also another good book by Anthony J. And he wrote a book called Estrogeneration. And he does a lot of work with genetics and stuff like that with clients one-on-one. And he's a biochemist, PhD, used to work at the Mayo Clinic. So he's brilliant. And that book is really good too, talking about estrogenic chemicals. There's astrazine that gets into the waterways. from farming and stuff like that, and that's commonly seen in the Midwest. So a lot of times people are concerned when they go on hormone replacement therapy. Men are concerned about getting gynecomastia, but actually these estrogenic chemicals are what's causing oftentimes gynecomastia, and then there's a genetic component usually. So if you're a young man and you already have gynecomastia, you probably want to get your toxin levels checked and then look at, okay, why am I genetically maybe hanging on to these toxins more than my friends who don't have gynecomastia and we grew up in the same place, so, or sibling. So that oftentimes I've really never seen testosterone replacement therapy in men cause gynecomastia. So I think that's a myth that I'd like to dispel and just kind of ease people's comfort who are maybe on the fence about doing testosterone therapy. And they're like, well, I'm concerned about all these side effects. And the most common side effect I see is a little bit of acne on the upper back, maybe shoulders. And if it's all over the back, then the dose is probably too high, or there's some personal hygiene issues or gut dysbiosis. I mean,
right. Yeah.
Yeah.
So can you talk a little, so for listeners who, feel they have low testosterone, or especially men, I want to discuss men, in general, like what lab testing are you running to get a baseline? So for those listening, if they want to go to their doctors or reach out to a functional medicine doctor, can you talk a little bit about that?
Yeah, that's a great question. So most people who come to me either don't have a baseline or they've only done total testosterone, maybe free testosterone. But I would say if you're really pinching pennies and you don't want to spend a lot of money on lab testing, go to your primary care doctor, say, I need a luteinizing hormone, so the LH, and I want a free and total testosterone. And that would be kind of the basic starting point, because we want to answer a couple of questions here. So, and probably sex hormone binding globulin too.
Yeah.
So, I mean, I have my basic panel that usually if someone's going to consider starting testosterone therapy or even herbal medicines and things and lifestyle stuff to increase testosterone, it's usually like a CBC with white blood cell differential and platelets, total PSA. Not because I think PSA is a great test, but you need to rule out an elevation in PSA above 3 before starting testosterone therapy. And also, there's some things you need to tell people before they get a PSA so there's not a false positive elevation. Like, don't ride your road bike for 8 hours the day before, don't have sex for 3 days before, don't do certain things 3 days before that could increase or affect your prostate. So that needs to be communicated. Also, exercising, doing a hard workout the day before can falsely elevate sex hormone binding globulin and lower your free testosterone. Getting your testosterone level checked before 10 a.m. So a lot of people bring a testosterone lab to me. It will just be a total. And I'll say, when was this done? And they'll say, oh, it was done right after work at 5 o'clock. Well, your testosterone is naturally going to be lower at that time, so you need to get it retested. I usually don't have people test their labs or blood tests 2 weeks apart to confirm if they have symptoms of low testosterone. You can pull up the ADAM questionnaire, ADAM, all capital ADAM questionnaire. It's a research-based questionnaire that has about, I think, like an 86% specificity for low testosterone in men. So ask questions like, do you have a low libido? Are you fatigued? Do you have decreased strength and endurance? Do you have weaker erections? It doesn't say, have you been diagnosed with erectile dysfunction? It just says, do you have weaker erections? So if they say I have a low libido and weaker erections on that form, then it's kind of a grand slam, potentially low testosterone. And to go back to your question before I go on too much of a tangent, I would have them do total testosterone, free testosterone, sex hormone binding globulin, total PSA, and maybe free PSA percent if first degree family relative with prostate cancer, like father or brother, and CBC, and probably estradiol sensitive. Estradiol as well for initial tests. Estradiol is not really that helpful to test, and maybe a total estrogen if they're just kind of like, hey, I'll pay for it all, let's do all the blood tests. It's also good if they have low libido to check prolactin. There's a lot of kind of elevations in prolactin I see that can be related to nutrient deficiencies and stress and nicotine and potentially caffeine intake. A lot of the guys that I see are drinking a pot or more coffee a day to get through their days, which I think if I drank that much, I would be running like 800 miles. So I can't imagine what their heart and their nervous system's going through.
I know.
So get those lab tests. If you're kind of like, okay, I want a visual of this, I have a free download on my website for andropause. It goes through diet and nutrition and what labs to order. I also like to order pregnenolone if there's anxiety or kind of like a low subclinical memory loss or memory issues or cognitive lack of cognitive aptitude there. So some people say, well, yeah, I have anxiety, but I don't feel like I need a medication. They may have low pregnenolone, and getting a DHEA sulfate and AM cortisol is a good idea too. Usually I look at all hormones. So if someone's, going to pay out of pocket and their insurance doesn't pay for these labs, you could spend $350 to $500 on a comprehensive hormone panel, and that would include thyroid and thyroid antibodies, fasting insulin, fasting glucose, hemoglobin A1C. So you want to look at metabolic dysfunction. You want to make sure some patients with a AM cortisol, which is a total cortisol before 9 a.m. So it's between 7 a.m. and 9 a.m. And then you can get a free cortisol pattern and do a Dutch test. And the Dutch test is your bioavailable and free testosterone in your urine. So there's no total testosterone. Total testosterone is helpful because it kind of gives you a picture of, okay, this is what I'm producing at this time of day. And it's also important for people to remember that all lab tests, all laboratory testing, unless it's done over multiple days, is a snapshot in time. So 24-hour urine is what everybody used to do for hormone testing. And then Mark Newman at Dutch Test at Precision Analytical Labs developed, I believe around 2015, developed his Dutch test panel, and then other people basically copied him. But he was at other lab test companies before that, and they weren't really excited about that testing. So he went and did it himself, and he's very good at those things. And you can listen, if you're listening to this and you want to dive deeper, you can listen to, his talks are free off of Dutch Test website. So if you want to understand more about urinary metabolites and hormones and things like that, you can listen to him, and other people talk for free. They have like free webinars open to the general public. But it's really important, I think, to get, if someone has the resources, to get a Dutch test complete for men, and then also get the blood testing, because there's two things happening here. Because we don't have receptor testing yet. Really, the only test I've found that tests receptors or anything to do with androgen receptors is the DNA test company. So the DNA company is out of, I believe, McGill University. They have a collaboration with them in Canada, and they have a bunch of DNA tests, and it's like $500 almost. And it's the good thing with DNA tests is you get it and you're done. You don't retest, but they test your ability to upregulate androgen receptors. So let's say, Joe Smith comes in, we get Joe Smith on testosterone cream morning and evening. He's starting to feel good, but then he doesn't really feel any better after a while. And we do the DNA test, and it's like, oh, well, you need methylation support. You need this. You have dopamine issues, and dopamine and testosterone are related. So we need to support your dopamine pathway with, copper and vitamin C, and maybe you need some SAMe to clear out, norepinephrine and epinephrine appropriately, and your COMT needs help, so you're not methylating out your estrogen metabolites. Oh, but you also don't upregulate your androgen receptors, so you can't grab on that testosterone and pull it into the cell, and testosterone and androgen receptors are inside the cell. So once they get inside the cell, if they're not able to create protein synthesis and help you make more muscle mass and increase vascularity and things like that, then they may not see improvement in their symptoms of like weaker erections, low libido, cognitive function, mood. And maybe it's more of trying to support those receptors as well. But what we get is when we do urine testing, is we can see the androgen and estrogen metabolites with what's in your blood. So I think a lot of people are kind of like, oh, it has to be blood. It has to be blood. And yes, the gold standard is to do serum blood testing. You want a free testosterone. An ideal free testosterone would be at least 20, ideally 30 nanograms per deciliter. So that would be 300 picograms per milliliter free testosterone, depending on the units used in the lab. And really nobody has that level naturally. So I think a lot of people are like, well, I just want to see what my body can do naturally. But if you have, symptoms of low testosterone, and usually most of the guys I talk to, their wife is the one pushing them to do something. Most of the time, not all the time. I think a lot of guys are waking up and they're saying, you know what, I used to go to work a 10-hour day, go to the gym for an hour and cook all my own meals and meal plan in my 20s and my 30s. And now I'm 40 or 42 plus, and I'm just dragging tail and I have no idea. Usually what guys say is, I don't feel like myself.
Yeah.
And they don't know, it's not like working with women where they're like, okay, this exact thing is happening.
A, B, C, D.
Yeah. Yeah.
So true. Even on the forms too, we noticed that guys, if it's like rated 0 to 3, 0 being nothing, 3 being, women are like 2, 3, 2, 3, 2, and men are like 0, 0, 0, 0, 1, 0, 0, 0. I'm like, no.
They're like, I'm good.
I'm fine.
Yep. Yeah, I'm fine. I just don't feel like myself. And I'm not lifting as much as my buddies or as much as I did 5 years ago or 3 years ago.
I can't get an erection. And what do you think about hormone replacement therapy for testosterone issues? Like, when do you think that's appropriate, if at all?
So I don't really have any hard, fast dogmatic rules. I used to say that if men were under age 35 or 40, that I really think they should do 3 to 6 months with lifestyle and natural things to see if they can bring up their levels. So, I think that it really depends on the individual and what's like at the root cause there. So, if they have really low testosterone, though, if their, free testosterone is super low, below 15 or usually it's below 12 for the most of the people that I see, and nanograms per deciliter, and their total is below, 500 or 450, then usually I think they need testosterone therapy, especially if they're older than age, 38 or 40. It's really hard for, there's like protocols that people can do where they can take, like 100 milligrams of DHEA until they get acne, and basically for a month or two, and then they drop it down to 50. And then they do other things like ashwagandha and maybe tribulus and some other herbs to try to bump their testosterone up and increase sleep and, rule out sleep apnea and sleep 8 hours a night, most nights, and do squats and deadlifts and sprinting, and really no other cardio at all, because cardio increases other things like cortisol too much, and it can decrease testosterone over long periods of time. So if someone's like on the chronic cardio kick, you may want to back off a little bit on that. I think it's possible if someone's 30 or 25 to increase their levels through quote unquote natural means or non testosterone replacement therapy methods. Most people that I see, though, even in their 20s now, are at least using something like a prescription of enclomiphene, which is compounded capsule that they take. It's basically like a cousin isomer of chemical isomer of Clomid. But that can increase sex hormone binding globulin potentially. So there's, if someone has a really high sex hormone binding globulin and low testosterone, that may not be indicated. And usually it's only indicated if they have low LH and low testosterone. So it's telling the brain to send a stronger signal of LH to the testes. So we want to, in the diagnostics, we want to see if it's primary, secondary hypogonadism. Is it the brain, the pituitary gland not sending the signal, or is it the testes not responding to the signal? Similar with other hormone pathways where you have that feedback loop, and if there's a break in that feedback loop, then we want to make sure we're ruling in or out the right thing. So oftentimes if people have like multiple concussions or mold or things like that, or they're under a ton of stress, they may not be sending that LH signal the way they should. And most people have had concussions either don't remember their concussion or nobody cared, because nobody really cares about concussions in modern medicine still. They don't really do much about it.
Yeah, I feel it's not talked about much, don't you?
Yeah, it's I would say most people, I mean, growing up, I grew up with two brothers. I played, lacrosse, and I mean, basically every day was a contact sport with two brothers and our friends. And, we were, growing up in northern New England and Vermont, New Hampshire, climbing trees, falling out of trees, 2 to 3 stories, landing on your back. And, that's a minor concussion potentially. So I think, and then you throw in car accidents that people have in snowy, cold climates. There's a lot of black ice, and you can just have a car accident going off the road, and maybe you don't hit anyone or anything, but that can be some minor whiplash, and you can get a minor concussion from whiplash, and people aren't talking about that. There's a great book called Brain Lash, written by a psychotherapist who went through 2 concussion recoveries. And she does like coaching for people who have had minor traumatic brain injuries, which are concussions. And there's nothing minor about them. It's just a kind of like a diagnosis designation. So there's, I think a lot of people don't understand, and men don't understand, that if you're going to get a prescription, whether it's enclomiphene or testosterone therapy, we still need to work on a lot of other things, and we've kind of talked about some of those things today, like, repairing the gut, removing toxins, not drinking so much. I mean, ideally people would really look at drinking like a once in a blue moon thing, and same thing with sugar and stuff like that. And, repairing the liver function. I mean, you really shouldn't, and no one should be getting testosterone therapy if their liver and kidneys can't deal with the testosterone and therapy and excretion of it and metabolism of it through the liver. So if someone has liver disease, or they have any cancer, they shouldn't be getting testosterone therapy unless it's like CLL and stage 0 or 1, and being, monitored once or twice a year with blood testing. So
what other contraindicators, like who shouldn't be getting, like patients with sleep apnea too, right?
Yeah. So I hear this all the time from colleagues. Oh, I gave, my patient Joe Smith testosterone, and I think he has sleep apnea. And usually I'm kind of like, oh, wow, you really should have ruled that out before they got testosterone therapy, and they should be using that CPAP while they're on testosterone therapy. The problem is the compliance is very low with those CPAP machines. So there's an engineer listening, and you want to make $1 billion if you can figure out something better for sleep apnea. There's a huge need if you know anyone with sleep apnea and how much they struggle with that kind of Darth Vader mask every night. So, but it does make a huge difference. It'll make a huge difference in everything: cognition, erectile dysfunction, testosterone levels. I've seen people's testosterone levels improve 500 points just by using their sleep CPAP machines. So you have to rule that out. You want to check PSA, make sure it's below 3, and then check it a minimum of twice in a year. As mentioned, any cancers, any liver, kidney dysfunction needs to be managed or ruled out. Yeah. So you want to do, and make sure that there's no issues with high hematocrit and hemoglobin beforehand. So sleep apnea will increase those numbers. So you'll see an increase in those numbers in untreated sleep apnea in the CBC. And then check at least hematocrit, hemoglobin, and red blood cells, like every 12 weeks or so in the first year. So that's why we do what I do with my patients on testosterone therapy in the first year. We're checking, after they start therapy in 6 to 8 weeks, we're doing a checkup, and we're not ordering $500 lab panel. It's maybe $100 or so. And then we're rechecking every 12 weeks after that. And we're checking the CBC, we're checking their total and free testosterone, we're checking their PSA, and checking on how they're feeling, because I don't chase numbers.
Right.
Yes, we have ideal ranges, but if someone has a 1200 total testosterone and a 30 free testosterone and everything else looks good, and they're kind of like, hey, I don't feel good, I don't notice anything, I notice something the first 2 months, but month 3, nothing, something's wrong, and we need to, maybe their dose is too high for them. Maybe they feel better at 800 total testosterone. And I think a lot of people don't understand that. So once you oversaturated the androgen receptors, usually people don't notice any difference, and then they start feeling worse. So a lot of people think, oh, well, what if I do bodybuilding doses of testosterone and they're on 3 different types of testosterone and trying to do some bodybuilding regimen illegally with some fitness trainer, which, who knows where they're getting that from. Supposedly it's reputable source, but we don't know if there's no lot number or expiration date on the vial, and you can't trace it back to a pharmacy, a compounding pharmacy. Ideally in the US, there's could be some issues of contamination or sterility, et cetera. But those bodybuilders are oversaturating their receptors, and that's why they do cycles. So they do like a 3-month cycle and come off, and then do Clomid, and then come back on, and it just completely wrecks their body. And we've seen, bodybuilders that are famous die in their 50s and stuff like that over the years because of their steroid abuse. And that's why testosterone has been labeled by the FDA as a controlled substance. It's not because it needs to be controlled. I don't think it needs to be controlled, so to speak. I definitely think it needs to be safely made and have a lot number and come from a reputable pharmacy and dosed correctly and monitored. But, a lot of things are controlled substances that shouldn't be controlled substances. It's because people abuse steroids, and then anabolic steroids, which are not the same thing as doing low dose bioidentical hormones at the lowest dose needed. So you could have somebody that weighs 180 pounds, and they're not working out a lot, they don't have a high demand for testosterone, and they're on maybe 120 milligrams a week. And then you have somebody that weighs 215 pounds, they're lifting 5 to 7 days a week, or exercising 5 to 7 days a week, they're having sex every other night or day, and they're using up a lot of testosterone. That person, and they're bigger, so usually with medication dosing, if someone's bigger, they need a higher dose, they may need 250 milligrams a week, which is usually kind of the highest that I go per week in dosing, or per 7 to 8 day period. Usually it's 200 milligrams or lower. But if someone's a really big person, maybe they're 260 pounds, they're built like a linebacker, they have a lot of muscle mass, and they're just need a higher dose. So, and you want to spread that dose out ideally. That's why cream is great, like a transscrotal compounded cream from a compounding pharmacy, or injectable, twice a week. So you're spreading it out like every 3 to 4 days. 3 times a week would be nice, but compliance drops. So someone's having to inject themselves 3 times a week with a subcutaneous or intramuscular injection, after a while, they're going to get pretty tired of that. So.
Yeah.
Well, thank you for giving us so much, information that people can take with them to their doctors, or, work with you. That's the thing, is people want to know, what do I ask for? What tests do I need? And I think one of the biggest problems with hormone replacement therapy is that these clinics that that's their go-to method with no other lifestyle changes and no monitoring of the testing after their first test. I mean, we've had so many people who come to us and I say, well, when's the last time they tested you? And they're on, hormone replacement therapy. And they're like, they haven't retested me just the one time. And I'm like, what?
Oh, no.
I know.
Oh my gosh.
Crazy.
So, well, can you let people know where they can find you?
Yeah, my website is apollohealthclinic.com. So APOLLO healthclinic.com. You can also just call the clinic if people call anything anymore, or text 206-779-7747. So, or go to apollohealthclinic.com, and you can fill out the application in the upper right-hand corner for a free discovery call with one of my team members. And we do those discovery calls every week, Mondays and Fridays. And we are accepting new patients who qualify. So usually we like to work with people that are highly motivated and they want to do more than just get hormone replacement therapy. I mean, it's great to get on thyroid hormone and the right dose of thyroid and testosterone or progesterone or estrogen for women and stuff like that. Pregnenolone, DHEA, maybe some herbs, and you'll feel better. But if we're not working on other things like mitochondrial dysfunction and stuff, you're just not going to feel better for very long. So people who are wanting to do a deeper dive than just like a low T clinic, and like you said, get their labs checked more frequently than twice a year. So
not even.
I know.
Not even. And then you
scary.
have an Instagram at Dr. Sam Madeira, right? That's your Instagram handle.
Yeah, Dr.
spelled out. Yeah, Sam Madeira. So and he put some great stuff up on there.
Yeah,
so
I have a lot of good info.
Yeah, and I have my own podcast. I'm on hiatus from the podcast. The clinic's just too busy right now to do podcasts.
It's a lot. It's a lot to do.
Yeah. So
we're all doing it. It's crazy.
Yeah, it is a lot. Yeah. I commend you guys for doing a podcast. I love it. I love doing podcasts and podcast interviews. It is a lot of work. And I think a lot of people maybe don't appreciate how much work it is, especially, we're not like Joe Rogan. We don't have a team of people, filming us and stuff. But people usually are like, oh, well, like, why don't you do video too? And, have like a team. It's like, man, that's a full-time job.
It is.
But people, if they want to listen to my podcast, I have over 60 episodes on all major audio podcast platforms, not on YouTube, but all other ones, iTunes, iHeartRadio, etc. And it's the Dr. Madeira Show. So Madeira spelled like the wine, Madeira. So
we'll link to all that too in the show notes. So
awesome.
Well, thank you so much for coming on. And we've really enjoyed all the things that you shared with everybody. I think a lot of people will be excited, and it's probably going to be a lot of women asking their husbands to listen to this episode. But thank you for being so thorough. We love that.
Yes.
You're welcome. Thanks for having me on.
Yeah. Yes. And thanks everybody for listening. We hope you have a great day.